Hi, thank you very much for having me. Can you hear me? Yeah, good. So yes, I'm the lead psychologist for the Rapid Diagnostic Clinic in Lewisham in Greenwich, but I'm also the lead for the Counsellor Psychological Service within the Trust as well, which is a useful comparison for me. So I'll just we're quite new. We were within the service from the start, and I'll explain a little bit about how the psychology evolved and also about our findings from the first year, and particularly thinking about how we've tried to make it a psychologically informed pathway, really embedding the sorts of principles that Liz was talking about within the RDC. Thanks. So if we move on a slide. So just to tell you a little bit about the service, I'm sure you probably all know, but just in case, the Rapid Diagnostic Clinic is like a 2-week pathway for people with non-specific suspected cancer symptoms, so that don't really fit within any other tumour group. And we started in a year ago now, based in Woolwich, and the psychology part of that was embedded from the start. It's led by a consultant GP and with some advanced clinical practitioners, HCAs. We've got a fantastic administrator, and between the two of us for the psychology input is with 2 days between the two of us. It's still quite a small clinic with a weekly capacity of about 30. Thank you. So we know that this population, that a lot of this non-specific symptoms like sort of unexplained pain, fatigue, weight loss, often may be impacted by psychological factors, but equally we know that lots of people that come to this service will have been a bit round the houses in terms of their healthcare, and maybe really quite distressed by now from a psychological point of view with what's going on physically. So we sort of anticipate that this group might have particularly high level of need. And in this context, our aim is to provide a really holistic, compassionate and psychologically informed service across the whole RDC, with the aims of improving patients' experience of the service and going through these numerous investigations, but also to improve access, really, and to help it reduce inequalities so that even people who are really struggling to attend are supported to get through the process. And that also then that they are appropriately signposted and supported to access other mental health or psychosocial services by really supporting people to understand the role of psychological factors and make sure that I think often people, it's a really hard thing to do, to refer yourself to talking therapies, for example, which often happens with IAPT, is that someone suggested they'll refer themselves. And often people aren't quite sure the role of psychological factors, or somehow feel that it means that their experiences are not being understood or taken seriously, and that they're being told, oh, it's just in your mind. And so a more comprehensive and personalised conversation about the role of psychological factors can really help with that. We're also aiming to pick up unmet needs and where psychological factors are impacting physical health. And sometimes I think that can help in terms of understanding the whole picture of the way someone's presenting, whether there might be psychological factors, for example, that are helping to explain weight loss. And then I'd say a big part of our role has been to smooth transitions so that we're not just sending people back saying, please refer to IAPT, but that we can make informed professional referrals that avoid that toing and froing and reduce potentially the burden on GPs for having to pick up some of that, which often means that we can make that pathway easier from a professional's point of view, who might have a bit more information than usual, but also help the patient to really be able to engage. And also with all these services, our aim is to support staff from a psychological point of view when often there is an impact on oneself from being with people who are very distressed. So moving on. So what we currently offer, one of the things that I'm I mean, I work, as I said, in cancer services generally across the trust. So we work closely with lots of MDTs. But one of the things that really stands out for me within the RDC is just the level of psychological mindedness and psychological skill, really, and communication skills, which I'm sure is down to the individuals, but I do think is in large part because we're led by a GP who's, you know, very psychologically thoughtful, used to talking to people about all kinds of different things, and she has also trained her colleagues in thinking psychologically, and I think that one of the things I really noticed is the really consistently positive feedback I get from patients going through the RDC, because they are communicated with so clearly by everybody in the team with a really personalized approach. And I think that's one of the things as psychologists as well that we're aiming to do, is to, with a very light touch, support the team in the way they deliver psychologically informed care. For a short period, for about 4 months, we offered triages to absolutely everybody who came through the clinic. We were just starting up, so we had the capacity to do that. But we really wanted to try and understand who was coming through the door and what the level of psychological need was. And I'll tell you a little bit about that. But having done that audit, we no longer do triages for everybody, but we pick people up at various points. Often they're referred by one of the clinicians, but I'll show you in a moment how we pick people up, and then we'll usually assess people and then offer. See, I think sometimes the assessment is like an intervention in itself, and here I think there's a number of roles of it. Firstly, it's to help people through the process who may be extraordinarily anxious, for example, about attending scans or about the fact that, you know, there's potential malignancy. People are often very frightened and may need support just to be able to get through. But I think that one of our key roles actually is in some of the things that Liz talked about in terms of minimizing distress and promoting adjustment. That people are often very surprised and concerned about the level of their psychological response to what's going on, and have become very distressed and tearful, for example, and helping people to really, by normalizing and understanding the impact of what's happening and supporting them with their own coping, I think really probably helps people with that adjustment process. But also I think that it may be reducing potential psychological harm, because it helps people to notice, normalize it, and find their own personal coping strategies really to manage it, which I hope prevents people from going on to needing further input. We will signpost very often to a very wide range of services, and I'll show you those later, but often we will make a professional referral or do that direct liaison with other teams. And obviously that's particularly relevant when it's the psycho-oncology team, because that we can make a very swift and easy transition to that. And often it will be the person that saw them in the RDC who can then see them in psycho-oncology. I say consultation training to the MDT. I'd say that with a very light touch, in that I do think we have a very skilled team, but I think our role often is just to be asking particular questions, and we help with writing leaflets. And for example, I've done a bit of work this week with our administrator and helping her think how much she might talk about psychology appointments with people on the phone. So it's in a supportive way. We don't offer something formal, and that's partly because we're very small, but we'll also work with other services within the trust, for example, radiography, to help them to support patients with difficult things like going through scans. And we also here to evaluate the service, and we've used IMPARTS, which is a King's-based questionnaire, King's College London University measure, which actually is basically the PHQ and GAD together. And we've used another measure as well, which I'll tell you about in a little while. Thank you. Moving on. So this is the pathway. And just to explain where and how we pick people up. So the referrals received by the RDC from primary care. And here, if a GP has made, identified some kind of potential barrier to engagement or some kind of need that might need support, that's really helpful for us, because we can immediately adjust to that or be thinking how we might want to support someone with. So, for example, you know, particular anxieties, or you know, as Liz was saying, something like autism, or you know, needing a carer with them, something like that. It just means that we can be thinking proactively how we can support somebody. The notes then get reviewed by a clinician, and there may be a triage phone call. And again, at either of those points, somebody can be picked up as needing additional psychological support and referred to us. Then somebody will receive an information sheet, and we talk about the potential of distress on the sheet and normalise it, and let people know that the psychology team's available, and offer them to get at that point to get directly in touch with us. We also ask everybody to complete these questionnaires, so we'll pick anyone who's scoring very highly at that point. And also the administrator will talk to people about how they're feeling about it, and will pick up potential distress and whether someone might need some extra support. Then I'd say the most of our referrals come from whoever sees them for their first medical appointment, and they're seen for quite a long time, for up to an hour, and often there is a lot of discussion about psychological issues. So that, I'd say, that's mostly when people are asked whether they would like to see us based on that information. And then again, people can come at the end of investigations, because for some people, having a cancer diagnosis might be very distressing, and so they may need input at that point. But actually, for some people, it might be more distressing even to not receive any kind of clear diagnosis when they were hoping for some kind of clarity about what's been going on for all this time, and to be left with yet more uncertainty can be really difficult. So there may be points at which we would see them at the end of their investigations as well. So we see them for we did see them over triage. Now we go straight to assessment, and then we will, as I said, I will often see someone twice, or I might give them a follow-up call. I very often will see a relative as well. So, for example, I recently saw someone who ended up liaising with his mental health team to think about whether psychology might be available there, which he'd previously refused, but actually is likely to be really helpful. But his wife, who'd been caring for him for a very long time, was really struggling herself. So I ended up having an individual session with her and making a professional referral on to IAPT services. So although it's very, very brief, it does feel like intervention of a sort, and it might just be 1 or 2 sessions, but we tend not to offer more than 2. And then our feedback is included with the feedback from the rapid diagnostic clinic back to the GP, and I'll really try and make sure that it, you know, very, very briefly, and I appreciate the importance of that, but that we do keep GPs informed about what's emerged, which obviously the GP will often be aware of, but whether we have made on any recommendations or referrals, for example. Thank you. Next. So I wanted to just tell you a little bit about the audit we did when we were triaging everybody. And so we literally targeted everybody. There were 117 people who were referred to the RDC during that period. And again, I would take my hat off to my colleagues, for they had a fantastic system of giving PHQs and GAD-9s to everybody who came through the door and following them at different points. And we would phone up people as well. So we had an incredibly high response rate, about 81%. So I do think we've got a really good representative picture of what was going on. And what we also did was we asked, although we triaged everyone who would agree to it, we asked the clinicians to let us know whether they thought they would have referred them really to us to identify potential need, because we wanted to see how their view of you know, psychological need compared with what you would pick up via a questionnaire. And we managed to, that meant in the end that we offered 92% of people triage. The other people were either significant cognitive impairment, or they left the country, or didn't engage with the service at all. Thank you. So in very brief, I'll just give you some of the kind of high level results. So 56% of people were willing to have a triage of some sort. and then these percentages are of all the people, of the 117 people that were referred to the RDC. 34% were identified by the psychologist as needing having some kind of specific need that might need some kind of intervention, and about a third actually received some kind of psychological intervention. And by that I mean either signposting, referral, or some kind of specific intervention, like some help with coping, for example, for anxiety, and 10% declined. So you can see it's pretty high levels in terms of a clinical impression of psychological need. So just moving on. Just in terms, before I look at the GAD and the PHQ, I just thought it'd be helpful to look at the literature. I know this looks quite old, and I did revisit that when Liz pointed it out to me, but actually this is where the literature's at, because well, these morbidity surveys, these are the latest, the next ones are due out now, but the thing is with this, they tend to cover the general population rather than, I wanted to really look at the people who were coming into hospitals. So you can see the rates of depression and anxiety in the general population are about 3 to 6%, but you'd expect in secondary care for them to be much higher anyway, people coming into hospitals. So, you know, up to a third of people you'd expect to be reporting depression just walking through any hospital door. So just in comparison, then, if we move on to the next slide, please. This slide shows in the yellow bar the percentage of people who were scoring above the clinical threshold on either the PHQ or the GAD. So if you look on the left, that was out of all patients who completed one of these questionnaires, 51% of them were scoring above the clinical threshold, which is extraordinarily high. And then you can see the breakdown, and you can see that 26% were scoring above the threshold on both. That was much, much higher when you looked at the people who the psychologist identified there was a psychological need and who then went on to accept a psychological intervention of sorts. And if you, this is directly comparable to the literature that I just showed you, that, you know, these are really high levels, even for people who are in primary or secondary care. Thank you. Moving on. Thank you. These are just a few examples of where I think there were times when the questionnaires really didn't tell the story. These were actually not people I saw, but a colleague saw. For example, the first person, she was referred for weight loss over a number of months and had scored very low on the PHQ and GAD, but actually on speaking to her, she'd had a lot of experience of bereavement and cancer, and she'd really withdrawn from social activities, stopped eating and cleaning, and was finding it difficult to concentrate. And she was signposted both to bereavement support and social activities. Secondly, this again, somebody who scored very low on the questionnaire measures, again spoke a lot about a high level of anxiety relating to health and difficulty sleeping, and actually was signposted to talking therapies, but picked up that for the first time he had talked about childhood sexual abuse, which again he was signposted to additional support, which all of these things may well have been contributing to the physical picture that wouldn't have been picked up by the imparts. Next slide, please. On the other hand, both of these people scored very highly on the questionnaire measures. The first person actually was very worried about the outcome, really understandably. She thought she probably had cancer, but had a lot of coping resources herself and a good social support network. So although she was very anxious, it was all very manageable, really, and was someone who was able to use the psychological session, but didn't really need to continue. And likewise, this man, you know, a lot of anxiety about it, but manageable within their context. So just moving on. I realise I'm running out of time now. I've talked and talked. So just to highlight, I'd say that this is to show what we offered in terms of signposting, referrals, but also the sorts of support. And I guess there's two things that I just like to highlight. Is one is that there's a vast array of places that we can refer to people to. It wasn't just the mental health services, but also if you think about the level of psychological need that was picked up on the questionnaires and in terms of clinical assessment, actually we have referred very few people to IAP, the NHS talking therapies, because actually when you talk to people, that isn't necessarily what's needed at the time. And I hope that this can be really cost saving, both in terms of patient, for the patient themselves, that they're not being referred unnecessarily to places, but also that IAP aren't getting unnecessary referrals. Next, please. And then just a quick summary of the use of questionnaires. I think Liz said some of this. It does underestimate anything other than depression and anxiety, really. There's lots of things it doesn't really pick up. It can also really overestimate referrals, which needs to be done on the need for specialist psychological intervention. It needs to be done on an individual basis, and often, certainly in the context of the RDC and in cancer pathways, you're going to pick up a very high level of anxiety because people are naturally very worried about what's going on. And also, there's a huge issue with literacy and, first language and so on. In addition, and I haven't included a slide on this, but what we discovered with this clinicians were much better than the surveys about identifying people who had psychological need, which is always nice to hear. And another couple of thoughts about questionnaires generally, they're very much based on a medical model of a thing called a depression and a thing called anxiety, when actually often this is people struggling to adjust to really difficult life circumstances. And people might also be scoring highly because of physical aspects that are often associated with something like depression, like fatigue or poor appetite. So again, it might be overinflating things. Next slide, please. So in summary, I hope what we're offering is something that's very holistic and psychologically informed, that enables people to have a really positive experience and come out feeling like they've really been heard and listened to, and that there's a plan of action that includes their psychological well-being. And I hope this means that actually, it's easier for people to move through the pathway. And in fact, the next slide, I just wanted to think about how that related to working with GPs in primary care. I think what we can do is, as psychologists, we're particularly in a good position to pick up on some of those psychological barriers to engagement if the GP flags those, but the whole team will do that. But then we can help people to engage with an understanding of the psychological issues that help them with forward referrals. And this hopefully helps GPs and reduces the pathway so that people aren't going backwards and forwards, and that we're making sure that we can really talk to GPs so they know what's been going on for the patient, really. Thank you. That's the end of my presentation, I think. But yes, it'd be really good to have a conversation and hear what people's thoughts are, or obviously I can answer some questions.
Brilliant. Thank you, Claire. And anyone would like to chip in at this point? A couple of comments in the chat, but no specific questions. I can see Judith, you've got your hand up. Can't hear you though. I think you're on mute at the moment.
Sorry, thank you. It was an amazing presentation. Very helpful. Sorry, I struggled a little bit just to understand. The GPs are the people that are doing the referrals, is that correct, to your organisation? And self-referral?
So GPs will refer to the rapid diagnostic clinic with suspected cancer symptoms.
Okay. How are you working How are you working with the GPs in order so that they can relate or engage more effectively with those communities? Because Lewisham, for example, I'm assuming it's a very demographic. There's a very high Black demographic within Lewisham. And one of the issues that I seem to consistently hear within the community is that although the Black community engage with their GPs, there is a very poor follow-on from GPs to referral on to secondary care. So how are you working with them to identify the needs of the community more effectively? Because I heard a lot of words around support, but what kind of support? Like,
That's a really good question, and thank you for raising it. And it is really, really important. I mean, in terms of how we engage with GPs and patients in this way, is that if someone we're very proactive in contacting patients if we think they might need extra support, or if they don't engage with the service, for example. So we will phone people and say, do lots of kind of normalizing and say, we understand it can be difficult for different reasons, and try to find out from that person what they might be finding difficult, and see if there is anything we can do to help.
No, yeah, I totally got that, because it sounds like you're very, proactive in contacting patients, which is great. Yeah. But again, how are you highlighting this? Because it seems to be that the initial problem seems to be with the GP and the referrals on. How's that being combated? Because if you're not picking up from the GP, then you've still got a large amount of the community that are not being engaged with. So how's that working?
Yeah, I'm not sure I've got a good answer for you with that. I don't think that there's, I think what we're doing generally within the trust is trying to engage with primary care and these kinds of issues in all kinds of different ways. So, for example, we've got a patient experience event coming up in the trust where we're inviting GPs as well as patients, as well as all kinds of different stakeholders, to talk about the whole process, to see where things can be improved. Now, it's not very specific to that very early point, but I do think it will include that, and all those stakeholders are involved.
Can I make a suggestion? I mean, because I'm so sorry, Polly, I know that I'm very inept, and this I'm just going to make a suggestion, because what I've found is that the organisations such as yourselves, you have these. What you've done is absolutely amazing. It's really needed, for sure. But really, we need to be working with primary care initially, at least, and they need to be engaging with, sorry to say this, but grassroots organisations that can be the bridge between the community and yourselves. And I don't see, and that's where the lack of engagement and these, initiatives that you're doing are very well, full chat, and they're required and needed. But if you're not actually going to do the pre-work before that to ensure that you have the right people in place to be the bridge between the community and the GPs and yourselves, then this isn't really it's not going to go to where it's actually needed. So, maybe, one of our first points of call should be to engage with the grassroots organisations. There are quite a few of us out there, and working with us to help you to empower our community in order to engage more effectively. But, until that happens, then I don't really see how this.
I think that's a great idea. What kind of organisations do you mean? Are you
like myself? I'm the founder of From Me to You, the Art of Survival. And why we were established was because I was diagnosed with terminal cancer in 2018 and given under a year to live. As a result of that was in 2018. I'm still here, luckily to say. As a result of the inequalities, or some of the inequalities that I faced along my journey, I set up the support group. And initially, it was just to have a safe space, to see if other people had experienced the same sort of things that I had. And clearly the group has grown phenomenally. And that's sadly as well, because obviously people are experiencing the same things that I felt, of not being heard, not being seen. And what we do is we go into the community, we raise awareness, we empower, we look at research, and basically we provide access to information. And we also do training, multicultural sensitivity training, because as well, another issue that does seem to be ignored a lot of the times is that, given that the UK now is, a buzzing, diverse, culture, we're not looking at how different marginalised communities engage with each other, because there are differences.
It's really helpful to hear, and I think those are the sorts of things we're really trying to do, and it's great to hear about your organisation, and I really take your point that we need to engage with those organisations right from the off. So thank you.
Judith, can I jump in here? I'm just really conscious of the time. Really value your contribution, and just to say that Judith, you're coming to speak at our December forum, aren't you? So you're coming back to this group in December. So obviously we can pick up that conversation then. Also, Judith, perhaps I can intro you to Claire to take some of this offline as well and see where you can work together. So I think sounds like there's some real opportunities there to collaborate to me.
Thank you so much for listening. I'm sorry for being so passionate. I tend to go on. I do apologise. But brilliant initiative, though. Amazing. Thank you.
Thank you.